You are tuned into the Dr. Tyna Show with Dr. Tyna Moore. For more, visit drtyna.com. On this episode of the Dr. Tyna Show, I get to sit down with my friend, Dr. Leonard Pastrana. Dr. Pastrana is my go-to peptide doc. He's a pharmacist who got sick of practicing what he calls Band-Aid medicine and since has changed his focus entirely to cellular optimization medicine. His passions include exercise science, nutrition, and health span optimization, and like me, loves to get patients off of pharmaceuticals when possible. This entire episode is about optimizing your Ozempic or GLP-1 journey and all of the adjunctive things that you may not have heard about that can really help dial this in for people. This is not a standalone monotherapy peptide. This is but one tool in a tool case of a comprehensive treatment plan. And you're going to find this episode fascinating. It's always so much fun to sit down and talk to Dr. Pastrana. So let's jump in. Dr. Leonard Pastrana, thank you so much for coming on the Dr. Tyna Show. I am honored to have you here. You've spent time talking to me several times in different formats, and your knowledge base is... So I am so excited to dive in today. We're talking about optimizing your Ozempic or GLP-1 journey, and you have such a unique perspective on things. So we're going to dive in just a second. But first, can you tell the audience a bit about yourself?
Sure. I'm a pharmacist, actually. I worked, your typical pharmacy job back in the day at CVS, and I handed out all those Band-Aids and didn't really see anybody getting better. And then I worked in the clinical setting. And one day I walked into a peptide certification course, and I just kind of fell in love with it because they were talking about not only medications or peptides, something that you can use for short term, but they were also talking about the similarities with exercise and nutrition and how to put a complete treatment plan together. And I saw these physicians in there that were, very healthy and very strong and very athletic looking and looked like they really took care of themselves. And it was something I hadn't seen in healthcare in like over a decade. And I just, I fell in love with it. And, I started not only getting my own health together, but also helping other physicians, put protocols together. And that's where, some of my different companies came from. And it started off as a hobby, and it was just a passion on how to optimize outcomes. And this is where we're at today.
Well, you're such a great teacher, and I have admittedly watched many of your webinars and tutorials on all things GLP-1. You actually are how I started my journey with that. I found some content that you had made, and I bought the course, and I quickly jumped in. And you know the story, but I'm going to tell my followers because I saw you months later at a conference, and I couldn't figure out how I knew you. And so I kept staring at you like, I know that guy. How do I know that guy? And then I cornered you and all of your staff. I was like, hey. So I came out as like crazy Dr. Tyna over here, but I was so excited because when I finally figured it out, I was like, oh, that's that guy. And one of the things that struck me about your education was you really double down on exercise and how important it is, and strength training, and just how critical exercise period is, and the pathways that it influences when it comes to influencing insulin sensitivity and really helping us reach our goals with our patients. So let's talk about that, because I think that's just fascinating, and it'll tie us into the rest of the conversation. I always say that strength training is non-negotiable. Exercise is non-negotiable. I heard somebody the other day say, if you're over 50 years old and you're not exercising every single day, you're missing the boat. Like, it's not even an option anymore after 50. If you want to live and thrive, you have to move and sweat every day. And that really struck me because it is so true. Outside of just insulin sensitivity, what are some of the big highlights of exercise that you talk on?
Sure. So for me, that kind of epiphany of exercise came when I was really truly trying to understand peptides. And I was looking, and we know peptides as these cell signaling molecules, but I was really trying to understand the biochemistry. And as a pharmacist, you're always thinking about the mechanism of action of why something's working. And as I was trying to understand that, you have to understand NAD and energy, and why is NAD even beneficial? What does it stimulate? What types of genes does it stimulate? And in understanding NAD, because NAD was a big topic, started to look at all the downstream effects of what happens when you stimulate NAD and you activate sirtuins. And it was things like fatty acid oxidation, or the inhibition of inflammatory markers, or the improvement of mitochondrial biogenesis, and the density of mitochondria. And so understanding how peptides were working and why they were influential in metabolism was something that I spent a long time thinking about. Now, in my own journey, when I was trying to understand exercise and why you can just say that exercise is good for you, but in my profession, I had to be educating other physicians. And so I have to get up on stage and talk to physicians and not just state things that are happening, but I have to actually show the research behind why what I'm saying is actually working and referencing the clinical papers. And as I was trying to reference why exercise was so important, I ran into the same, molecular pathways as that. Hey, the same things that exercise is doing is what we're looking at of these compounds. Exercise is stimulating things like PGC1 alpha that has to do with fat oxidation and things like mitochondrial transcription factors to improve the density of mitochondria. And that's when I kind of had that epiphany. Hey, what we're doing here with peptides is exactly what we're doing on a molecular pathway base when it comes to exercise. And what happens when we put these things together is where we get these tremendous outcomes. Before we even start talking about insulin resistance, just the way glucose is disposed of by itself. And if I jog my memory back, going into some of the recommendations that I was taught in school, because you were never taught anything like this in school, is thinking about, why does a type 1 diabetic not able to take insulin before they exercise? It's like, because that exercise acts like as this natural insulin. It increases the disposal of glucose by itself. So it's like all that information as a pharmacist was in my brain. It was just never connected well until I had to start teaching it and understanding it better. But that's how it started, was just understanding peptides and understanding that exercise was doing the same thing.
Well, exercise is like the ultimate peptide. It hits so many marks, and there's nothing quite like it. And that's why I am just beating the drum that it's non-negotiable. And for everyone listening who's new to me, I didn't used to be an exerciser. I was like a sit on your butt girl and chain smoke and be super skinny, 90s heroin chic girl. I was like the punk rock girl in Portland, smoking cigarettes and just like wasting away to get as skinny as I could, because that's how all the supermodels looked at the time. So exercise is something that I only recently, I should back up. I was a gymnast as a kid. So I was a high level athlete. And then I did a whole lot of nothing for a long time, to the point of probably some health damage. And then rediscovered exercise and, became like, I sound like a cult leader about it, because it's just not negotiable. And so that's the part that I want people to understand. And maybe you can bring some more clarity to this. People can't just be cranking GLP-1s or Ozempic and like hope for the best. Like, dosing aside, that's such a small part of the conversation. The real conversation is not just protecting muscle mass, which we'll talk about, but just exercise in general, just moving, like to optimize the whole system. You rattled some of those off, but can you double down on maybe 2 or 3 of the most important ones that you talked about a moment ago?
Sure. So if you think about why GLP-1s were even invented initially, and initially it was for neurodegenerative diseases, but they found that it was decreasing blood sugar so much. But if you think about just insulin resistance as a whole, like how what is it that GLP-1s are doing to decrease glucose or dispose of glucose? And one of them is insulin dependent, right? So we know that insulin, when it's secreted, it stimulates what we call something called GLUT4, and that translocates and goes to the cell surface of the muscle and opens up this passageway for glucose to go into the muscle as it's supposed to, the correct way. And when you're metabolically flexible, this normally happens. Now, GLP-1s, what they're most known for is the fact that they help that secretion or that stimulation of insulin at the right time. And this is what's so beautiful about peptides, because you would, if you're thinking about, what is insulin resistance? Well, it's hyper, it starts with hyperinsulinemia. So why do we have this compound or this peptide that's secreting insulin? Isn't that the opposite of what we want? Well, no, it has a modulating effect. It does it at the right time, postprandial, after you eat. Exactly when glucose goes up is when it brings this insulin into the cell. Now, there's not only insulin-dependent ways of this translocation of GLUT4 that brings glucose into the cell, but there's insulin-independent ways. And this is stimulated by things like exercise. So when we exercise, the cell recognizes this deficit in energy, and so it increases things like what we call AMPK. And so AMPK is also independent of insulin, grabs this GLUT4 and brings it to the cell surface. So not only does exercise do that, but GLP-1s do that as well. So most people know it as secreting insulin, but GLP-1s also activate AMPK and have this insulin-independent way of getting glucose into the cell. So we're just talking about general just metabolism and energy production. Because what happens when things go wrong? Well, glucose doesn't, get into the cell. And now we have this increase in liver fat. And now you start to see increases in triglycerides. And now you start to see increases in non-alcoholic fatty liver disease. And that's this progression of where insulin resistance can start in just blood glucose levels that can get missed if they're not checking the right levels. And now it starts to show up in the liver and we start to have other problems. And this is simply just a function of metabolic flexibility and something that is activated, just by exercise, just by the cell recognizing this deficit of energy. Like, oh, there's a deficit in energy. Well, I need to increase AMPK. And then there's all these downstream effects of all these wonderful things that happen. But the way that Big Pharma is going, they're creating peptides that are just mimicking this. And we're seeing this with the next generations of peptides where they have dual agonists and now triple agonists that are, they're basically just mimicking exercise, which is, why we have this clue as to it could be so potent if you do this along with exercise as well. And then we're not even getting into how you feel mentally, right? When you're moving your body, when you're exercising, because there is that component. And some people have mentioned it with GLP-1s when it comes to potential depression or stress management issues. But when you're exercising, you're increasing that brain-derived neurotropic factor that improves your cognitive function and your stress resilience and your stress reduction. So, the combination of exercise is so important. It's not just a metabolism thing. It's not just a weight loss thing, but it's an overall sense of well-being, and it has a lot to do with your cognitive function as well.
Well, it makes so much sense. I think people look at these peptides as drugs and they think, well, I'll take the drug and more is better because more is better is the American way. And I don't need to do anything else. I can just take this and my appetite will be crushed and I'll lose the weight. And I'm over here trying to have an entirely different conversation with people. I'm trying to help them utilize it in the smallest doses necessary to really optimize their overall well-being and their longevity. And people ask me all the time, is it good for this condition? Is it good for that condition? I'm like, you're missing the point. That's not the conversation I'm having. This isn't about, can this treat this condition? That's messy. In naturopathic medicine, we're trying, and the way I hear you talk, it's funny, you talk like a naturopathic doctor, whether you knew it or not. But you talk about, just optimizing the cell.
Yeah.
We'd say it a different way, but I'm trying to I'm trying to get homeostasis back in check and with a little hormetic push on the system, right? And I'm trying to get people feeling better, and I'm just trying to get people to understand the mechanism of action of these peptides, and therefore, can it be applied to these symptoms, if you will? It's not the disease process I'm trying to get to treating with, like, somebody asked me the other day, are GLP-1s good for gout? And I'm like, we got to back up and understand the mechanism of action. And then can we extrapolate from there? Would this be a helpful tool in a comprehensive tool belt? But exercise is at the top of that tool belt. Like that, we're not doing anything instead of, we are stacking. And if nothing else, if the folks on GLP-1s would do nothing else, even if they were still just eating garbage food, but it was less garbage, at the very least, add exercise to the equation, because that'll actually make you want to start eating better, don't you think? Like most people generally start wanting to eat better when they move.
Yeah, absolutely. The way that I think about it is well, I put in all this hard work. I moved. Do I want to ruin that? Like I got started. It was such a such a good start to the day. And one of the biggest things that I see people making a mistake in is that they've never had control of their appetite, and GLP-1s give them this control of their appetite. And they initially lose weight, and then they start to kind of skip meals, or they will just have like a bag of potato chips. And unfortunately, they'll get some weight loss initially, but then they'll start to feel slow down, they'll plateau, they won't have the energy, they'll start to lose their hair. And has nothing to do with GLP-1. It's just a nutrient deficiency. And it's one of the bigger mistakes I see people make is, okay, you finally have control over what you're eating. You got to make sure that it counts. You got to make sure that you're getting the right amount of protein. And when you're exercising, you're hungry enough to eat that protein that you need, because sometimes it is difficult to get the right amount of protein in. And if you're not exercising, it makes it even more difficult. So no, I agree with you. Exercise absolutely makes you want to eat better.
Yeah, that's such a great point too, is I think that exercise helps keep a regulation of the appetite. It makes you hungry, but It controls crazy urges. I say this as someone who was a former anorexic, and I always say that strength training, people say, how did you get, I mean, I had a lifelong struggle with anorexia and bulimia. And people say, how did you get out of it? And I'm like, I started strength training. It made me hungry enough to want to eat, but it also helps somehow with those dopaminergic pathways to choose the right foods.
Yeah.
And GLP-1s do the same thing. I noticed that GLP-1s give me that same kind of control. And I've actually had several people report to me that GLP-1s have helped them overcome their eating disorders as well. There's something about it hitting the right dopaminergic pathway that and reward center that I don't know what it is. Maybe you understand this better, but people are reporting that they're feeling not just in more control of their of like having a big, crazy high appetite, but of low appetite too, oddly enough.
Yeah, absolutely. It definitely has an effect centrally in the brain. It has a pathway in the reward center of the brain. And we see this with a number of different things. We see it in alcohol. We see it in cigarette use. We can see it in their relationship with food. So there's a lot more when it comes to GLP-1s, especially when it comes to addiction, when it comes to certain types of behaviors, because of that effect on the reward center of the brain. And some people that are so used to being stimulated on that reward center of the brain, they actually initially feel a little sad. And I think I felt this as well once, because I love food. I love the thought of food. I love the ceremony around food. I love thinking about cooking the food and what ingredients I'm going to buy. And when your appetite is decreased and you're not necessarily thinking about it, you're actually missing something. And so there's a little bit of changing that relationship with food. Absolutely. So there's a physical aspect to it that we like to talk about a lot, but there's definitely a mental aspect to it, which is it's not a negative thing, but it helps you realize that relationship that you had with food and make sure that it's a healthy relationship for sure.
Yeah, for sure. Good stuff. Okay, so let's talk about muscle.
Sure.
My argument is that they're measuring lean mass loss in these studies and not specifically just muscle. And we've talked about that in the past. I'll have you extrapolate on what we think about that. And then is the muscle loss the big crisis? And, all this clickbait, propagandized headlines we're seeing, is this all as real as everybody is making it out to be?
Well, there's a lot to unpack there. The first question you want to answer, well, is it the GLP-1? And we know that for sure is not the case. So when you look at studies with GLP-1s, we know it improves muscle blood flow. We know it has an anabolic effect. So it's not the GLP-1 medication itself, but it does have to do with a couple of factors. One, we know that there's going to be a caloric restriction. So people were already not eating enough protein. And so now with a caloric restriction, they're eating less protein. So that's the more obvious one. Right. There's the resistance training, but even independent of resistance training, the truth of the matter is some people are losing a lot of muscle mass, and it's more described like the case I said earlier, where someone's just eating a bag of potato chips. But really, where people are not paying enough attention is what GLP-1s are actually doing. GLP-1s decrease thirst intake, and so people are drinking a lot less water. Also, when you have a caloric restriction, there's a lot of water in food. And so you're having less fluid intake there as well. Now, why is that so important? Well, cellular hydration has a lot to do with metabolic control. And when you have cell shrinkage or water outside in the extracellular space, you actually put the cell in this catabolic state, where if you have cell water going into the cell or improvements in intracellular water, it's more in this anabolic state. And so you have a patient that is eating less protein, they are caloric restricted, they're drinking less water, their cells are in this shrunken state where it's enhanced protein degradation. So not only do you not have the substrate of protein that you're eating less of, but your cell is in this protein degradation state that's further enhancing that the inability for protein synthesis and to protect muscle. And so this is where people get in trouble. And it's a very simple fix with the right amount of protein and cellular hydration. And it's more than drinking water. There's a number of different ways that we can do that that you know about, of course. But I think that's the bigger picture, and that's the picture that people assume, like they're pretty good at knowing, hey, we got to improve protein intake, but I don't think this hydration and setting up the cell in a place to win is what is being overlooked a lot, and it has a lot to do with hydration.
And there's studies showing that if you're dehydrated, your strength is in the bucket. I mean, your strength in the gym is significantly improved. I think I saw a study years ago. I can't remember where I saw it, but it was like 75% difference in those who were dehydrated versus hydrated in the gym so far as their strength gains went. So
Yeah.
like and the other topic, I mean, just to throw a wrench in this muscle conversation, is that strength gains and strength overall is so much more important than lean mass size or muscle mass size, right? Like a strong individual, a strong elderly person is a much healthier person than a overly muscled elderly person.
Absolutely. And this isn't, we're not, making this up. There's plenty of studies that say this, right? So what some people are obsessed with is muscle mass. They say, okay, people are losing muscle mass, and maybe they have an in-body or they have a DEXA scan where they can show that people are losing muscle mass. But did you measure that patient's strength before they started on therapy? And this is something that we're doing now. We make sure we measure their strength because the studies are very, very clear. They looked at it. Independent of muscle mass, muscle strength is the biggest indicator of morbidity and mortality. And so that's one thing that people like to jump to. Muscle has everything to do with, sarcopenia when it comes to mortality, but it's not muscle mass, it's muscle strength that is definitely more important. And you brought up another great point about hydration or intracellular water. And so they studied this not only in athletes, but they studied this in elderly population. So in an elderly population, they found those with greater intracellular water. So remember, the intracellular water, the cells expanded, it's in an anabolic state. They had less frailty and an increase in performance. So studies in elderly population. We also saw studies when it comes to increased intracellular water in athletes, which it's hard to move the needle in an athlete because they're pretty optimized. And they showed that over a course of a season, those with higher intracellular water perform better. When they looked at leg extensions, they looked at grip strength, and they found that even in not only chronically over the season, but they found in the acute setting that those that had less intracellular water had less performance or less strength in a number of different markers. So intracellular water, absolutely. You were mentioning it before, but just to double down on that, there are plenty of studies showing that increase in intracellular water has everything to do with strength that ties us back into why hydration is so important, not only for the maintenance of muscle mass, but when it comes to how you're performing in the gym and your strength, hydration plays a massive role.
So you have an interesting way of looking at hydration. It's not just salt water. You're not just giving people electrolytes. So can you talk about that?
Yeah. So of course, electrolytes are very, very important. But one of the things that we did in some of the masterminds and some of the other physicians that we've been doing a lot of research with is it started back in COVID actually for a number of other reasons, but a lot of the physicians were using specific amino acids in their high-performing athletes. So we had some physicians that were training high-performing athletes, and when they're working out so hard, if you think about CrossFit athletes or if you think about people that are doing 1 hour, 2 hour workouts, one of the main things that you want to do with them is maintain muscle mass, and because they're burning so many calories. And one of the drinks that they were using was getting specific amino acids together that were amino acid osmolytes. So we're not talking about branched chain amino acids or essential amino acids. We're talking about specific amino acids that have this that are neutral osmolytes, meaning that they draw water into the cell. So ones like alanine and glycine and glutamine. And so they would mix that mixture with some creatine, because creatine is also an amino acid. It's also an osmolyte, so it draws water into the cell. And so they were mixing that in their water for the day, 2 to 4 liters of water. And this had an amazing ability in professional athletes, not only to improve their performance while they're exercising, but to maintain that muscle mass. And this is something we started to realize once GLP-1s came out, and once we saw people were decreasing in muscle mass, but patients weren't compliant with it. They're not going to buy 4 or 5 different amino acids and put it in there. So we did help them with formulating something called iCell. That is these amino acid osmolytes with creatine. It's a powder. They put it in the water and they drink it slowly throughout the day. So typically, an electrolyte drink or any other type of supplement, you would just put it in 8 ounces and drink it. That's not how this works at all. You actually have to drink it slowly throughout the day. So one of the recommendations we have for most of our patients is they're drinking at least 2 liters of water. So they put this amino acids and creatine in the water and they drink it slowly throughout the day. And that way we know they're getting their 2 liters of water at minimum per day, but we're getting these amino acid osmolytes. We're improving intracellular water. We have their cell, in an expanded, volumized state, and it's in a state to win. And so anything else we do with that, exercise, other peptides, it just makes it exponentially better.
I've been using it, and I actually add it. I take my Element electrolytes to flavor it, and I add them together. And
I do the same thing.
It's such a great blend. Like I notice improved cognition for sure, but most notably just a boost in my energy overall, sustained daily energy. I really go through these sort of like highs and lows in my energy throughout the day, to the point where there's like a scheduled nap in most of my days. I have like a 3 p.m. Pacific Standard Time. There's a nap involved. And it might just be a short rest, but there's some kind of like, let me lay down and recharge. And I've noticed not needing that. And in fact, feeling like I want to get up and do something, like some kind of exercise or movement. And I'm not making this up, because you sent me some like a month or so ago, and I've been doing it diligently in preparation, because I was like, let's see if this really works, you know? And I'm impressed. I think it's a good product, and I think it's helping. And you're right. There is sort of a lack of hydration with the GLP-1s. And it's something I double down on inside my program, where I tell people, like, do not forget to drink water, because it's crazy how many people come to me. My husband the other day, he's like, I have the worst headache. I don't know what it is. I don't know if it was that extra glass of wine last night, and my husband doesn't get impacted by alcohol. So I was like, no, it's not that. And he couldn't figure it out. And I was like, have you had any water today? And he'd been working, I think he'd worked like an 8-hour shift at work, and had come home, and he had not had any water since waking up that morning. And I was like, maybe that helps.
But that's then easy to do.
Yeah, but you pee it out if you're not getting these other cofactors in there. So I don't know. Interesting. I just think it's a really interesting, what you're onto something. And
the people, there's a lot of things that we take because we know that they're good. And then there's things that we have that people really feel. And you can absolutely feel from one day to the next, like how well you're lifting, how strong you are in the gym. And ISL water is definitely by far one of the best things that we know people are going to feel the difference. And then one of the things that we do, we have a longevity assessment center where we have a DEXA scan machine. We do VO2 max testing. We do strength testing. One of the things that we're doing with case studies is saying, because it is annoying. I do get frustrated when I see, all these things talking about GLP-1s and muscle loss, and you have to be careful. And we have many case studies that you might have seen me present on before, where we've had people gain muscle mass on GLP-1s before while losing fat tissue. And that's hard to do. I mean, if you ask those in the bodybuilding, community, they're either doing one or the other when they're focusing on that. But we have had patients that absolutely will lose fat tissue while gaining muscle mass. Not that that's what you need to do, but you need to at least maintain muscle mass. And the other thing is, you might have a patient that has a very high BMI, 38, 39, and they're metabolically inflexible, and people are upset that they might lose a couple pounds in lean mass. It's like, well, this person's in danger. They're in an inflammatory state. They're metabolically inflexible. They're well muscled, which is another thing that you have to look at when you're prescribing GLP-1s is, you have to identify, is the person under-muscled or they have sufficient muscle when you start? Because I'm not worried about that patient that's losing a couple pounds of muscle mass while we're getting them metabolically flexible again. And by the way, if you test how strong they are, I've had patients that lose a little bit of muscle, but they get stronger in the process. So we already identified that. Is it muscle mass or muscle strength that's more important? And so if your patient's getting stronger while they're losing weight, even if there's a little muscle mass in there, it's very nuanced. And that's why I hate when the conversation is just like, oh, you're losing muscle mass, because there's so much more to this conversation. Tell me more about the patient, where they started. Did they get stronger during the course of therapy? Because that's going to really tell us, if we're doing the right thing or not.
Amen to that. I don't think most doctors are tracking that. And to their defense, they're not equipped to do so. They're not nerds about it like we are, and they don't have the equipment to do it. And they're just trying to help their patients. But you're so right. I mean, the real risk of excess adiposity and insulin resistance for long periods of time and metabolic dysfunction to that level of like, they're already like, by the time people get to type 2 diabetes, it's a real dumpster fire of metabolic health. I don't say that to be derogatory. It's just people have normalized it. Like, oh, you have type 2 diabetes, and the doctor telling them has type 2 diabetes, so it's no big deal. Here's your metformin. And I'm like, no, we have this peptide that can actually heal the metabolism if done right. And if these other factors are tracked, and also, certain things are emphasized, like exercise and proper hydration. So it's crazy. Well, and the other thing that I've talked to you about in the past that I've mentioned here and there is that I think that these people going in oftentimes have a lot of marbling and fatty infiltrate in their muscle. And so when that gets burned up through the improvement of their metabolic health, then their muscle mass is going to be, quote unquote, less. And really, they're probably just losing volume of some of this is going to be fatty infiltrate, which was pathologic.
Yeah, absolutely. And that's something that people don't realize. And I've heard you mention that before. And it's like, yeah, there's weight's being lost, but it's not all muscle. There is, like you said, there's fat in there as well. That it's leading to that insulin resistance. That fat within muscle is one of the biggest drivers of that insulin resistance. And so it needs to go.
Yeah. And there's fatty liver and fatty pancreas. And I mean, there's infiltrate everywhere. And I don't know how good these DEXAs are, or these whatever scanning devices people are using to really differentiate that from, maybe it can look at visceral fat volume wise, but is it getting these nuanced areas where fat is infiltrating itself and marbling into the tissues?
Yeah, it's tough with an in-body. They give you a score. With a DEXA scan, it's a little bit more accurate, but I like with the DEXA scan, you see that the kind of like a heat map. So you can kind of see that marbling. And it's really cool to see a patient go from kind of lit up on one of those scans to you can see the big difference. But like you said, not every physician can have a $70,000 body composition scanner in their office. But I think that's something we're actually working on is making those more accessible.
And patients who are on these, any human that's on these peptides, there's a lot they can do and take matters into their own hands. Even buying an inexpensive scale from Amazon and then just kind of tracking that way. Some of these are pretty decent. I have one in my Amazon store that I suggest people use by a company called Withings, which is just like looking at is your visceral fat going up or down? Is your muscle mass going up or down? I know it's a percentage. I know it's kind of a gross reading and not super accurate, but it at least lets you know you're on the right track. But I will say, if you're dehydrated, those levels are all off. All bets are off on that thing.
all bets are off. And that's what we have some of our staff, because we have all types of machines all over the place, and they'll come in. Perfect example. Someone came in a couple of days ago, like, what the hell is this? And she slams her readings on there. And I'm like, look how much extra water you have, because it measures, the in-body at least measures how much water. I'm like, you have 3 more pounds of water. You can't necessarily look at that. But to your point, I have a Withings at home. And what we're looking there is trend, right?
Yes.
So yeah, it's not going to be the most accurate gold standard, but you can see the trend, and they're definitely very, very beneficial as long as you're trending in the right direction. But I wouldn't live or die on 1 pound of these readings, because it can kind of drive you crazy depending on your water.
But there's a lot we can do even without fancy schmancy tracking devices. For the average American, I get a lot of pushback from people talking about these peptides, because they're like, not everybody has access to these things. Not everybody has access to this or that or the other. And I'm like, there's a lot you can do in your house with some, milk jugs that you fill with water or sand, and some push-ups and a pull-up bar and an inexpensive scale that gives you some trends. There's people can manage.
No, absolutely.
Okay, so that takes me to your revelation around low-dose leucine, which is also fascinating. So can you talk about that?
Sure. So we were, at some cellular medicine conferences where it's more biochemistry type heavy, looking at the recent literature. And some of the literature that was coming out was very interesting on low doses of leucine. Now, leucine is typically thought of as something that activates mTOR as it does. It's thought about for protein synthesis. And usually about 2.5 grams of leucine will stimulate protein synthesis and activate mTOR. But there were some cool studies showing that at low doses of leucine, it was doing something else and not activating mTOR. And it was actually decreasing the amount of NAD needed to activate sirtuins, which is very interesting, because those are a lot of the metabolic and a lot of the exercise type pathways that we pay attention to. Sirtuins get, a lot of buzz. NAD gets a lot of buzz, but not for what we're talking about here. NAD gets thought of as like this youth molecule, but the way we're looking at it is the way it's kind of transferring energy. And sirtuins are, thought of as this longevity gene, but the way that we're looking at it is, what are the downstream effects of activating these sirtuins? And so what they found is that these low doses of leucine can decrease the amount of NAD that you need to activate sirtuins, which is what stimulates the activation of PGC1 alpha, that has to do with fat oxidation and mitochondrial function and the upregulation of antioxidant enzymes, everything that we talked about earlier. And so a lot of the studies started utilizing low doses of leucine with other co-activating compounds. So other things that stimulated that same pathway that had an effect on sirtuins or NAD. And there were some pharmaceutical companies looking at it with things like Viagra, sildenafil, with Other things like low doses of resveratrol, low doses of B6. And so there's some really interesting work being done there with some human trials. And we saw decreases in triglycerides and a number of different things. But what we were so excited about was this is the same exercise mimetic pathway that we were always trying to stimulate. And so when we were looking at patients taking peptides or GLP-1s, all those studies were done with exercise as well. And so we thought if we can come up with compounds or other things that mimic these same pathways, it would be super beneficial. And so some of our partners in the pharmacy network were compounding low doses of leucine with small amounts of these other co-activating factors. And a lot of the physicians just reported back, tremendous results. A lot of the physicians they'll only prescribe GLP-1s with things like Leucinergy that has low doses of leucine with other co-activating compounds. It's just a very simple thing that you can do, understanding a little bit about what low doses of leucine is doing to add to therapies to really further enhance therapies. And so Leucinergy is probably one of the number one selling supplements that we have because most physicians are prescribing it with their GLP-1s. So interesting work being done there. But I've always been fascinated by the improvement in NAD efficiency, not necessarily by giving NAD precursors, but there are all these other things that we can do to enhance our own endogenous utilization of NAD, and low doses of leucine is pretty interesting part of that.
I love that. It almost is like a hormetic kind of pathway where you're getting the body, you're giving the body a little bit of something. I mean, I guess kind of hormetic would be more of a stressor, but like you're giving the body a little bit of something and it's stoking the pathways to go. And that's so cool because I remember when NAD came on the scene several years ago, and it just was like, again, that more is better kind of attitude. I never bought into that necessarily, taking high doses of it.
Yeah, we were all thinking about it, right? We understood what NAD was doing. It was doing some pretty amazing things. We can look at the pathways, but like you said, they were thinking more is better. And even with resveratrol has gotten like a really bad rap recently. But I don't know why it recently came out. We knew that resveratrol was an activating SIRT1, right? And we knew that very high doses of resveratrol can be actually pretty damaging to the mitochondria. But even back in 2012, we saw studies showing that when you combine resveratrol with low doses of leucine, it does activate sirtuins, right? Because it's decreasing that what's called KM, the substrate needed to activate sirtuins. And so it's just about finding the right dose and the right, the right mixture, and utilizing, small doses. More isn't always better. Perfect example is a study what they did with low doses of leucine and nicotinic acid. So nicotinic acid or niacin has been shown to be great in reducing cholesterol. It's antithrombotic, anti-inflammatory, but people can't handle a lot of nicotinic acid or niacin because there's insulin resistance, there's nausea, there's a bunch of things going on. But they had a study with low doses of leucine and nicotinic acid, and they found they can decrease the amount of nicotinic acid by 95%. When in combination with low doses of leucine. So typically you'd give nicotinic acid in like 1 to 2 grams. They found that at a human equivalent of 75 milligrams, they can get the same therapeutic outcome when combined with low doses of leucine. So simple little things like that where you don't have to have the highest dose ever are just really interesting things. And of course, what you see in a preclinical model and what you see biochemistry wise isn't always gonna work. But this is, luckily, as pharmacists, we're one-on-one with physicians all day long, and we get to see, is this stuff actually working or not? And we've just gotten so much great feedback, and physicians showing us cholesterol levels and showing us everything that's been beneficial for the patients, leveraging some of these supplements.
I love it. Well, because these are supplements working in conjunction instead of the supplement sort of vibe right now, which is, let's take nature's Ozempic. Let's take these things that are going to stoke GLP-1, or take these things that are going to, they're not mimicking them. They're trying to get the L cells to pump out more GLP-1, but sometimes the L cells are pooped out. Sometimes people have leaky gut or atrophy in their gut lining, or they've got, inflammatory bowel disease, or even IBS for longstanding. And those L cells are not necessarily going to do a whole heck of a lot when you throw some berberine at them. So taking advantage of some of these other pathways to use synergistically and adjunctively along with your GLP-1s, I think is such a cool, you guys are doing some cool stuff. So you mentioned cholesterol and cardiovascular disease, and I think that's a big hot topic right now with the use of GLP-1s, right? The the select study, the select trial that came out, and just even recently them saying that it wasn't just because of the fat loss, which everybody wanted to argue about, that it was actually independent of the fat loss. It was the GLP-1s themselves were having an independent impact on the cardiovascular system. But there's other things you can add in there too, synergistically. So you have another product that you were telling me about that I don't entirely understand. So it's called Citronol. Can you tell me about that one?
Sure. So citronol is actually Citronol LNA, and the LNA is for what we just kind of talked about, was the leucine and nicotinic acid, leveraging that science. But what citronol is, it's these polymethoxylated flavones, and one of the core ingredients in there is nobelatin. And we have all types of studies when it comes to nobelatin. It's studied in cancer, it's studied in a number of different things. It's studied in improvements in circadian rhythm, but with nobelatin, it's also a potent activator of SIRT1. So we see this decrease in inflammatory gene transcription factors. We see this its beneficial effects on lipids. And so we have all these preclinical models, and I want to make sure to be clear, we can't necessarily take stuff from just preclinical models, but mechanistically, it's doing a lot of great things. So something that we studied for a long time, but luckily, and this is something you don't see typically when it comes to supplements, is that they actually tested it in humans, citronol. And the other component of citronol is tocotrienols. And what tocotrienols are interesting is that they work similar to statins, but differently in that they inhibit HMG-CoA reductase. That same enzyme that statins, they competitively inhibit. Well, tocotrienols work similarly in that they speed up the degradation of that enzyme, right? And so they put this together with these polymethoxylated flavones and tocotrienols, and they actually have human studies with citronol that we can lean on, where they showed a decrease in ApoB, a decrease in LDL, a decrease in triglycerides. And so having a component like that in combination with low doses of leucine and nicotinic acid. It's just this amazing combination that we use, and we see a lot of practitioners using it. Some practitioners feel a certain way about statins, some add it to statins, but we have more and more patients that getting the muscle pains, getting the deficiencies in CoQ10. And there's a lot of reasons why someone may not want to take statins. And there's a lot of physicians that I run into that just aren't comfortable prescribing it. And so this has been a really great option, the Citronol LNA. So we see this because I don't know about you, but when we're looking at blood levels or we're looking at the biomarkers, we see crazy increases in ApoB, more than ever in triglycerides to HDL ratios when we're looking at insulin resistance. And it's such an amazing combination with GLP-1s because we can see what GLP-1s are doing in the studies when it comes to triglycerides, especially even tirzepatide, right? When you're thinking about these dual agonist GLP-1s, tirzepatide, they work very similar, but tirzepatide does something different when it comes to white adipose tissue, right? And that's one of the bigger difference between it and semaglutide, where it helps the healthy expansion of white adipose tissue. And so it increases lipid storage, because what happens when you have this, the white adipose tissue is not able to expand, you have this lipid spillover, and this is where you have ectopic lipid accumulation, what you were talking about earlier. And tirzepatide, or this dual agonist, has the ability to expand fat tissue like that. And so this is why we see in a lot of studies with tirzepatide and semaglutide, tirzepatide was having even greater reduction in things like triglycerides. Now, semaglutide has those outcomes. Now, did anything actually happen? We're waiting on tirzepatide to come up with those outcomes. But we can see just from biomarkers that tirzepatide is decreasing things like triglycerides. So that's a go-to for most of our practitioners that are identifying patients with more of a risk for cardiovascular disease if they have elevated ApoB levels, or they have they have that genetic predisposition to Lp(a), or they have a family history of cardiovascular disease. GLP-1 or dual agonist with Citronol LNA is their go-to, and we can see those reductions happen pretty quickly. So if you combine that with exercise, you can really have some pretty amazing outcomes for sure.
I love this idea too, because not everybody is looking to utilize GLP-1s at this point for weight loss. Some of them are wanting to utilize it for cardiovascular support. And I think even Medicare recently came out and said that they would cover it for cardiovascular disease, which unfortunately my mother-in-law's doctor is unaware of. He's not keeping up. But this is something that's coming down the pipeline. I believe that they're going to probably start covering these things through insurance for the use of cardiovascular.
Semaglutide got an approval for cardiovascular disease, so it's just a matter of time before the other ones get it. And I know that there have to be guidelines, and you have these guidelines where you have to have a BMI of 30 or more, or BMI of over 27 with a comorbidity. But we're smart enough to recognize that we can't necessarily always look at that. I mean, I have a friend that has a BMI of 30 that has 12% body fat and is stronger than ever and is a CrossFit athlete now, and metabolically flexible. I mean, if I just looked at his BMI, I would make a wrong decision in what compound I wanted to utilize compared to someone that might have a BMI of 26 or 27. But when we get them on an in-body or a DEXA scan, they're loaded with fat tissue and they have low muscle mass. So we fortunately, we have better tools, and I understand why we have to have specific guidelines and why they must be followed. But, luckily we have practitioners out there that are looking a little bit more deeply into this, fortunately.
Well, and it's deceiving because it's the thin on the outside, fat on the inside, what we call skinny fat. It's those little skinny ones that I saw in my clinical practice having sometimes really profound cardiovascular disease. And, Dr. Peter Attia has said this, that often the first sign of cardiovascular disease is the heart attack or the cardiovascular event, and so these sort of, I call them like the little, like metabolically brittle, these sort of skinny metabolically brittle. And my concern is that people who crank GLP-1s for long periods of time without doing any of these other adjunctive therapies, or at the very least exercising and trying to eat nutritionally dense, I'm afraid they're going to end up over there.
They're going to turn into that, right? Yeah.
Yeah. I mean, that's really the concern. And I get why they're being vilified across the media, because people are seeing that in front of their eyes. I get messages from followers all the time. Like, I'm watching my mother waste away in front of me. She looks like a ghost, and those people are going to come out with lower muscle mass than they went in, and they're going to be metabolically brittle. And now you've got this skinny little kind of, those are, to me, the cardiovascular accidents waiting to happen.
And those are the toughest too, because you have someone under muscled and they're lower in weight. And so to get them to eat more and eat more protein, and especially the big thing that's not being talked about enough, because this is something that we actually measure in our lab, is their metabolic slowdown. So their energy expenditure is going down because they've lost that muscle mass, because they're eating so much less. Their energy expenditure has gone way down, and their metabolism has slowed down, which is going to be there's going to be the propensity for weight regain. And it just makes it more difficult when they come back and try to do it the right way. And that's why some of these GLP-1s that are coming out in the future that have that are increasing energy expenditure are pretty interesting. But that's another one that's a big one, and that's why we're seeing a lot of that weight regain, is that lack of muscle and that decrease in metabolism.
Yep. And they were kind of dosed into it.
Yeah, unfortunately. I know when we first started, we were seeing most of the results happening at the first or second dose. I think one of the biggest mistakes that was made is that people read the studies, 2.4 milligrams of semaglutide provided X amount of benefit. And so physicians thought that, well, it was their job to get patients to 2.4 milligrams. And no matter the side effects or not. And unfortunately, I think that was a really, really big mistake, because they put people in a tough bind where they're just kind of desensitized to it, and their metabolism is slowed down. Where I see practitioners that had great results at lower dosages, if they were doing all the other things, adding the other supplements, adding other lifestyle modifications, making sure their patients knew that they had to get stronger or at least maintain their muscle mass. There's a big difference between one practice and another when it comes to results. Utilizing the same medications by just simply a couple lifestyle modifications and supplements that can make all the difference in the world.
Absolutely. Right. These adjunctive, it's all the things that my followers are always asking, what's the dose? What's the dose? I'm like, that's the most irrelevant part of the conversation to me, is what's the dose? Like, that is not where the magic is. The magic is not just in GLP-1 solo monotherapy. Like, that is not it to me. There's adjunctive things that need to be going on. There's hormones, there's gut health, there's muscle mass, and it really all depends on the patient in front of me, right? Like, who is sitting in front of me? What do they need? And it's a bigger conversation than we can cover in a podcast, or that, I can make in a post online on Instagram. It's crazy to me that, I've got people coming in, like, writing me hate mail novels of like, you're gatekeeping. I'm like, I'm not gatekeeping anything, but I'm not going to tell people how to dose on the internet. First of all, that's not great medicine to practice. And second of all, it depends. It's so individual and varied as to where I'm finding, because I'm finding at even doses lower than the starting dose, I'm finding success. But that's reserved for people who are metabolically optimized going in. I mean, are we getting anti-inflammatory benefits and such? Yeah, probably. But like, to really move the needle, I feel like it's almost like the gift to the people who are already metabolically optimized that a little touch does such wonderful things.
Yeah, and they experience that with a lot of things. It's not just GLP-1s, but I think you hit the nail on the head where I get frustrated when I hear some of these questions being answered online, because it's just not the way medicine works. There's so much more to the story. There's so much that's going on mentally, physically, their history, inflammatory things that can be going on, gut health issues that can be going on. So everybody's trying to answer the question in a vacuum, and everybody's arguing over the wrong question. It's you can't answer these questions. It's there's so much more that goes into it.
Yeah. Medicine is an art. And
Yeah.
in my program, I'm trying to teach people that art, and the program's really designed for clinicians, but I allow the public to come in, and it's been interesting. It's the folks inside the program are really enjoying the way I'm trying to break this down, but it's a longer conversation than, a podcast or an Instagram post. So speaking of education for clinicians, you guys have a really cool program that I am signed up for that I love, that it's called Nucleus Pro. You have so much great education. I've learned so much about peptides from you. Do you want to talk about that a little bit?
Sure. So that's the main thing that we do is we help practitioners, optimize their patients. And one of the things we do through New BioAge is we provide a lot of education. And so we actually not only provide education on a number of different compounds, but we also have one-on-one consultations with physicians. So if physicians are putting protocols together or they have questions on patients, they can talk to some of our pharmacists one-on-one. And we've been on the phone with hundreds of practitioners. We kind of see what's working and what's not working, and we try to share that information with everybody. And we're going to continue to be putting out more and more education. It's our favorite thing to do. It's a lot of fun. My favorite thing in the world is when we put something out, or we have a conversation with a practitioner and we get that email back about somebody that had plateaued or was stuck, or just wasn't getting the results that they were before, and then those success stories where things kind of turned around when we started talking about other things that are available for them. And that's kind of really what drives us, is those emails. So our favorite thing to do. Any practitioner can sign up.
Yeah, I'll put the links in the show notes, and I'll put the links for the general public is able to purchase these supplements, right? Some of the supplements you talked about.
Some of the things that we formulate stuff for many different companies, depending. And then this is another conversation that we have with physicians as well too. Is certain physicians treat specific patients, and so we get to know your patients, what type of patients you're treating, and then help you develop certain plans. But yes, absolutely. The supplement part of things are available to the public.
Awesome. I will put the links in there. I have a 10% off offer for people that you guys have been kind enough to extend to me. So I will make sure that's in the show notes as well. Well, this has been so fun. Thank you so much for your time, as always. I learned a ton from you. You're an amazing educator. If you guys are clinicians, I know a lot of clinicians listen to this show, a lot of health professionals. The Nucleus Pro has been so helpful to me. I've learned a lot there, and I continue to. And you guys are always crafting new and creative ways to educate on so many there's different medications that could be compounded that I had no idea about, that have really incredible effects that I've learned from your platform. So I'll put all that in there. And anything you want to leave the audience with? Have we not hit on something that you want to make sure we double down on?
No, I think we did. Thank you so much. I have so much fun talking to you because you talk about all of my favorite stuff. So the conversations are always so easy. Thank you so much. Thank you so much for really putting yourself out there and putting that education out there, because I know it's your passion, but I also know it's not easy. I know when you're putting yourself out there, you get the compliments, but you also get the other side, and it's really brave of you to do what you're doing. And I really appreciate it. Thank you so much.
Thank you. Thank you for coming on the show today, and thanks for being in my circle of folks that I can bounce ideas off of. So we'll have you on again.
Yep. Thanks.
Thanks for listening to the Dr. Tyna Show. This is a Wellness Loud production produced by Drake Peterson and mixed by Mike Fry. Theme song is by John the Guild. You can watch the full video version of this podcast inside the Spotify app or on YouTube. As always, you can email the podcast at podcast@drtyna.com. That's DRTYNA. And if you like this episode, please rate, review, and subscribe on your favorite podcast app. You can also find all of my offerings on my website at drtyna.com. For more shows by my team, go to wellnessloud.com. See you next time, and thanks for listening. This podcast is for general informational purposes only. It does not constitute the practices of medicine, nursing, or other professional healthcare services, including the giving of medical advice. I am a doctor, but I am not your doctor. No doctor-patient relationship is formed. The use of this information and the materials linked to this podcast is at the user's own risk. The content on this podcast is intended not to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.